this video, we will discuss thyroid eye disease, the pathogenesis and clinical features. Thyroid eye disease, also known as thyroid-associated orbitopathy or Graves' ophthalmopathy, is a common autoimmune orbital disorder and represents the most frequent cause of bilateral and unilateral proptosis in adults. Thyrotoxicosis. It is the excessive secretion of thyroid hormones. Graves' disease is the commonest cause of hyperthyroidism. It is an autoimmune disorder with IgG antibodies that bind to TSH receptors and stimulate the secretion of thyroid hormones. It is more common in females. The clinical features of thyrotoxicosis are weight loss despite good appetite, increased bowel frequency, heat intolerance, sweating, palpitations, nervousness, irritability, fatigue, enlargement of thyroid gland, warm sweaty skin, tremor, palmar erythema, thyroid acropathy, pretibial myxedema, and cardiac manifestations like sinus tachycardia and other arrhythmias. Risk factors for thyroid eye disease. Smoking is the most important modifiable risk factor for thyroid eye disease. The risk increases with the number of cigarettes smoked, and smoking cessation reduces disease severity. Women are affected more commonly, and radioactive iodine therapy may exacerbate ophthalmopathy. Pathogenesis of thyroid ophthalmopathy. It is an autoimmune reaction against orbital fibroblast, which causes inflammation of extraocular muscles, interstitial tissues, orbital fat, and lacrimal gland. This leads to pleomorphic cellular infiltration, increased glycosaminoglycan production, and osmotic water retention, leading to increase in volume of the orbital contents, particularly the muscles, which can swell up to 8 times their normal size. There may be a secondary elevation in intraorbital pressure and the optic nerve may be compressed. Subsequent degeneration of muscle fibers eventually leads to fibrosis, which exerts a tethering effect on the involved muscle, resulting in restrictive myopathy and diplopia. Thyroid eye disease typically progresses through an initial inflammatory stage, which is characterized by red, painful eyes and is usually self-limiting within 1 to 3 years. Only 10% develops serious long-term ocular problems. A fibrotic quiescent stage follows, in which the eyes are white, although a painless motility defect may be present. Clinically, thyroid eye disease is categorized into soft tissue involvement, lid retraction, proptosis, restrictive myopathy, and optic neuropathy. Each component contributes differently to morbidity. Soft tissue involvement. Soft tissue involvement presents with grittiness, red eyes, lacrimation, photophobia, puffy eyelids, and retrobulbar discomfort. The signs include epibulbar hyperemia, which is a sensitive sign of inflammatory activity. Intense focal hyperemia may outline the insertions of the horizontal recti. Periorbital swelling is caused by edema and infiltration behind the orbital septum. This may be associated with chemosis and prolapse of retroseptal fat into the eyelids. Tear film insufficiency and instability is common. Corneal signs are exacerbated by lid retraction and can include punctate epithelial erosions, superior limping keratoconjunctivitis, and occasionally bacterial keratitis, thinning, and scarring. Lid retraction. It occurs in about 50% of patients. Patients may complain of a staring or bulging-eyed appearance, difficulty closing the eyes, and ocular surface symptoms. The upper lid margin normally lies 2 mm below the superior limbus. Lid retraction is suspected when sclera is visible above the limbus. Lower lid retraction shows sclera below the inferior limbus. It may occur alone or with proptosis. Overaction of molar muscle is postulated to occur as a result of sympathetic overstimulation secondary to high levels of thyroid hormones. Fibrotic contracture of the levator palpebrae and inferior rectum muscles associated with adhesion to the overlying orbital tissues is another probable mechanism, together with secondary overaction in response to hypo or hypertropia produced by fibrosis. Some of the lid signs in thyroid eye disease are Dalrymple sign, which is lid retraction in primary gaze, Cocker sign, which is staring, frightened appearance of the eyes, and Von Graffe sign, which is lid lag on down gaze. Proptosis in thyroid eye disease. It is typically axial and may be bilateral or unilateral, often symmetrical but may be asymmetrical. It is frequently permanent. Severe proptosis can cause exposure keratopathy and may lead to corneal ulceration and infection. Restrictive myopathy. It occurs in 30 to 50% of patients. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. The symptoms are diplopia and discomfort in certain gaze positions. The inferior rectus is most commonly involved, causing limitation of elevation and vertical diplopia. Other defects include abduction followed by depression followed by adduction. Optic neuropathy. It occurs in up to 6% of patients and is caused by compression of the optic nerve or its blood supply at the orbital apex by the congested and enlarged recti. It may occur without obvious proptosis. Symptoms include impairment of central vision in conjunction with other symptoms of thyroid eye disease and reduced color intensity. The signs include reduced visual acuity, reduced color vision, diminished light brightness, RAPD, visual field defects, and the optic disc may be normal or swollen or rarely atrophic. A commonly used classification for the severity of thyroid eye disease has been issued by the European Group on Grace Orbitopathy. Based on this classification, thyroid eye disease can be divided into sight-threatening, moderate to severe, and mild. Sight-threatening thyroid eye disease is characterized by either optic neuropathy or corneal breakdown. This requires immediate intervention. Moderate to severe thyroid eye disease has one or more of the following: moderate to severe soft tissue involvement, lid retraction of 2 mm or more, diplopia, or proptosis of 3 mm or more. This has sufficient impact on daily life to justify the risks of immunosuppressives if active or surgical intervention if inactive. Mild thyroid eye disease has one or more of the following: mild soft tissue involvement, lid retraction of less than 2 mm, transient or no diplopia, or proptosis less than 3 mm. This has only a minor impact in daily life, insufficient to justify immunosuppressives or surgical treatment. Some exam relevant points are: smoking worsens thyroid eye disease. Inferior rectus is the most commonly involved extraocular muscle. Optic neuropathy may occur without proptosis. And UGOGO classification assesses the severity of thyroid eye disease.